Hi, Wes.
Hey, Bennett.
How are you? I'm gonna be going to your island tomorrow.
Oh, well, you got meetings over here.
No, my Alfredo's mother passed
Yeah,
away.
that's right. We know that.
Yeah, so my
Services.
son actually is came in from DC with his family, so
Yeah.
they're already there. I'm going tomorrow.
They got services tomorrow.
There's services tomorrow and Saturday. But
Mm,
over the weekend, there's like family activities, that sort of
yeah.
thing.
Gil had told me about that, so I sent a note to Fredo.
Yeah.
Yeah.
Yeah, sad because she would have been 100.
Oh, too bad they never make up. Yeah. That's good long life though, you know?
I know, but 1 month short.
Yeah. My mom was like, I think a month short of 90 when she passed.
Oh, my
You know,
mom is 90. Yeah, we just had a party for her.
yeah, but good long life, that's good, it's nice to hear.
And she did not suffer.
Yeah, that's right. The most important part, yeah.
Yes. Hang on, I'm just trying to text people that
Oh,
thanks
sorry.
for val
Be quiet.
thanks for
Hey,
validating.
Tani, I miss you, Tani.
Aloha, how's it going? Aloha, how's it going? Sorry, my mic.
Okay.
Yeah. What's new or old?
Nothing. Nothing.
Good to see you both.
Yeah.
Hang on a second.
I finally saw the one Ohana video
Hello, this
with
is
all the
Bennett.
different communities
Oh,
that
just
that Rich
I'm on
emailed
the
out to
middle
all
of a
the
call,
employees maybe a
but
few
I
months
saw
ago.
you. So can you do it
Nice.
from your thing?
Oh yeah.
I,
Yeah. Okay.
I'm not on
Thanks,
the
huh?
email list.
Okay. Bye-bye.
Oh, not. You create the email list, right?
No.
Oh, Caroline is here. Thought you were gonna be late.
I thought I was too, but I'm here. I'll be on in a second.
Good.
Thanks.
It seems like people have other things that they or maybe they're just because Pokii said she cannot come. She has something else. How are you, Tani?
I'm good, hanging in there.
Good. That's good.
How about you?
Oh, crazy. I was just telling yeah, we had a death in the family, so I'm
Oh,
off to
I'm
Maui
sorry.
tomorrow. My ex or my former mother-in-law,
Mhm.
but I was still close to her. So,
Yeah.
and I was married for 27 years, so I guess you can't just sever ties like that, right? Yeah.
Right, and that's family, right?
Mm-hmm. Yeah. And she's a mom of my grandchildren. I mean, my children.
Right, their grandma, right?
Mhm. Yeah. Such a nice
Sorry.
lady too. Oh,
Yeah.
thank you, thank you. No, she was 100, almost 100, 1 month short of 100. I
Wow,
know.
really?
We were planning already her 100th birthday. I
Oh,
know. And then sadly, but the good thing is she did not suffer. She went to her
Good.
daycare that morning, and then at noon she complained of a stomach ache, and they took her to the hospital, and they said, you got to have surgery if you want to get better. And she's like, no surgery. And then she was in pain, so they gave her some sedative or what, not
Hmm.
sedative, like painkiller, and she slept, and that was it. Half a day later, she
Quick.
passed.
Yeah,
Yeah, very quick.
might be the
That's yeah,
best way.
that is the best way.
It
oh.
is. It
I think I
is.
want
She
to
did
go like
not.
that.
She did not suffer. She did not. Yeah. She and the only thing is we didn't say goodbye. We couldn't say goodbye to
Oh,
her,
yeah, that's the
right?
hard
Because
part.
you always think, oh, you're gonna have more time.
Hmm.
Yeah.
Mhm.
That's a
So
good
what?
intention for a meeting to always
I
say what
know,
we need
right?
to say.
Yeah.
Yeah.
Now, should we just start? Because I know Wes is raring to share.
No,
Yes.
And we are so excited.
I don't know, man. You poor guys.
Give yourself more
No, no,
credit,
no.
Wes.
No, I know we have so much to share, and I think the fact that you're ahead of it, at least the curve, you know? So in the kingdom of the blind, the one-eyed man is the king. You're the one-eyed man.
Yeah, yeah. I've been called other things. We will go there, right? So,
Yeah. You know, I think we do have some other new people. Kat, I think we should start with some introductions. And Daintree, I think this is, um, I don't know, maybe Kat, you may have been in one or two meetings, so my apologies to you.
Oh, no, not at all. I apologize if you can hear the weed whacking. I telework.
Can't
But
hear anything.
oh, shucks.
You're fine. You're fine.
Okay.
Yes.
No, we
go
can hear
ahead.
you. You sound great. That's what I meant to say.
Oh, okay. So I work at UH West Oahu. I am the director of the Mapuna Lab, but I am here as a student, a doctoral student of public health. Kendi Ho kindly connected me with your circle as we were discussing my study 3, which is on it's a pilot study looking at demographics for workforce development. So I'm
Oh.
happy to be here. Thank you so much for having me.
Wonderful.
wow.
Okay, let's have introductions because for Kat and Daintree's benefit. So Ida, go ahead.
Hi, my name is Aida Wen. I'm a geriatrician with the Department of Geriatric Medicine at the John A. Burns School of Medicine, and also PI of a grant, HRSA grant, the Geriatric Workforce Enhancement Program. And so it's an education grant that we do a lot of work with our partners.
Thank you. Wes?
Hi, I'm Wes Lowe. I'm a guest to this committee. I'm work with Ohana Pacific Health. We have a bunch of skilled nursing facilities and rehab centers, home health, adult day health facilities across the state.
Thank you, Wes. Tani?
Aloha mai kako. My name is Tani. I work at the Executive Office on Aging, on Alzheimer's disease and related dementia services. And I work for Caroline.
Great. Candy?
Hi, I'm Kathy Wyatt. I am the founder and president of Holly Holy Hawaii Adult Daycare Centers. I've got 3 now, one in Kaneohe. I'm also the president of the Hawaii Family Caregiver Coalition and members of a bunch of boards, and Caroline knows.
Yeah,
She's president in lots of places.
Thank you. Thank you, Kathy. Candy?
Hi, everybody. I'm working with Christine Ishida at Center on Aging and also Research Associate Program Evaluation with a small local firm. And happy to see everybody here to push the needle on long-term care workforce.
Great. Troy?
Good afternoon, everyone. My name is Troy Suyoka. I'm in the Hawaii Department of Education in career and technical education. And one of our pathways that we have for our students is health services, where this would probably be most applicable. So nice seeing all of you.
Thank you. Daintree? Nice to see you.
Thank you. Nice to be here. Hi, folks. Daintree Bartolas. I apologize for being late. I'm the executive administrator for the Hawaii State Council on Developmental Disabilities. And yeah, I'm just glad to be here. We've teamed up with Caroline folks, with the aging and the IDD population about the workforce needs for individuals to work and also for individuals to people that work with our individuals. So thank you so much.
Thank you. Audrey?
Hi, good afternoon. I'm Audrey Suda-Nakagawa. I'm the advocacy director for ARP Hawaii. I'm glad to be here.
Great. And Wanell?
Hi, Manel Kaneshiro, Workforce Development Branch for the Department of Education.
Thank you, Wanell. Last but not least, save the best for last, Caroline.
Thank you. Sorry about that. I wasn't trying to hit the screen. There's a mosquito in my office and I get very itchy. But anyway, my name's Caroline Kareira. I'm the director of the Executive Office on Aging. And just thanks to everyone for joining, for helping with this. And if you're on some of the other subcommittees for our long-term care plan. It's really going to help to move forward a lot of the initiatives to help our whole community overall. So thank you so much.
Thank you. So we have three things in the hour that we have set for this meeting. So first, we're going to have Wes Lowe, who's going to be presenting about the interesting, innovative approaches. Oh, I'm underselling you, Wes. Okay, if you know me, I could really sell you. He's like, no. Oh, he's been on this trajectory, this path of trying to manage expectations, but we know he's gonna blow us all out of the water, right, Wes? But anyway, we're so privileged to have him, and this conversation, I mean, this idea of having him as a presenter actually came about as he was sharing with a steering committee of the innovative things that they're doing. So we're gonna hear from him. We're gonna hear from Caroline, who's going to talk to us about the big picture, the steering committee, and then we're also going to be talking, Candy Ho is going to be sharing with us where we're at as far as we did a survey, what the priorities are, and then from there, we're going to close after the discussion to share about next steps, because we do have a very ambitious timeline. There is a cadence to this that we need to be mindful about, because it's not just, of course, within our own subunit, we also have to contend with the steering committee and of course the legislative agenda and calendar. So with that, I'm going to turn the table or the platform now to Wes, who for his presentation. You can share your PowerPoint. Go ahead.
Okay. Where do you do that? Oh, share screen.
Yeah.
Well, first, before I get started, first I'm going to apologize in advance. I forgot who might be on this committee, so I'm going to be using their slides probably, Aida and Wanel and everything from a previous thing, just to sort of show where we're at. And just again, I'm like, Benetta's right. I try to manage expectations. I kind of threw this together fairly quickly. It's not entirely about workforce development, but it's around the things that I think we need to do to support workforce development. Frankly, it might tie in a little bit to some DOE things, I hope also. So it's a little bit of all over the place. With that, I will share screen and see if I can do this right. Okay. Let's see. I'm not sure that I can make it go into. Do you see it in presentation mode, or are you guys still in regular screen? Oh, it doesn't matter.
Regular.
Anyway, I'll just
PowerPoint screen.
You still have the slides on the side,
Okay.
but you want to go slideshow and then from the beginning. So go
I'll
on
just
slideshow.
I can just do it this way.
Okay, no
I
worries.
figure I'll screw up. Technology and me don't really like each other too much. Okay, so the first part is, I think there's so much going on in the workforce development area, and I sort of want to just review it. I think there's been some there might be some updates to things. I think there was some money that was approved for DOE along the healthcare side, and I don't mean to put Wanel on the spot. They may have some more information. I'm just loosely associated with, but I wanted to recap sort of the workforce part and then go into some of the things that we think is we're struggling with on the workforce side and some potential ways to address it. Yeah. So, and these are slides that actually was presented back in our session back a few months back. So, so on the workforce side, I think there's a lot of workforce development. There's the certification programs that the college is doing. I know that there's we have some long-term care nurse residencies at various places, and they are working on transition from nursing to specialty practices. So that's going on, and there's a whole bunch of certification pipelines in the high schools. Wanel and Troy, this is again back a few months back. These were the schools that were doing that. And then I think I'm sorry, I'm getting all the names mixed up. I mean, who's working with Christy? Oh, it's Kendi, right? So we got the elder care pathways going on. And we're trying to do more certifications and trying to get more people interested in home and community-based services and dealing with our kupuna. And then obviously the sort of the one thing that seems to be working pretty well is our CNA to LPN bridge glide path. So I think there's a lot of really good stuff going on there now. It doesn't necessarily help that much on the home and community-based care side, though. This is all trying to get people to higher levels of income, et cetera. Just into the healthcare workforce. So I think that's good on one side, but the other side is I've noticed that we really aren't necessarily affecting the home and community-based services workforce. And so I kind of started thinking about it and some of the things that have happened and some of the things we're trying right now is number one is one of the problems getting people into entry-level positions. Those are the people that would really radiate towards the home and community-based service side is that there's a huge competition for entry-level workers right now. And I think, I'm sorry, we have a guest on that was this demographics. I'm sorry, I'm going to try to find the name there. It was,
Oh, that's me, Catherine.
Yeah. So yeah, it's even more intimidating. I got people who know demographics and stuff, but certainly the problem is we got an old aging population, and we really don't have many workers, and there's huge competition for it. And we certainly got that problem. And I think that if what we're discovering is that if we don't solve some of the income levels and the housing levels, all of our workforce development efforts will end up having people move away. We need to solve that. Otherwise, I think that there's going to be a problem developing workforce. Housing prices. I mean, so I think if we employ on all islands, but frankly, Maui and Kauai, the housing prices are just killer right now, and it's impossible to get workforce. And then if you get an entry-level person, you can train them, but the problem is if they can't get housing, they're going to just look for other jobs, they get higher pay, or they're going to leave. That's our impression of things right now. So we kind of came to the conclusion, and actually this was in something called the Maui Economic Recovery Commission, where we're trying to help recover the Maui economy, that you can't talk about workforce development without talking about housing. That's sort of, I guess, what people are thinking. So I think that we want to change the narrative to talk about, I guess I've seen a presentation is to solve these community problems, you got to grab the web whole. You can't just do parts of it. Otherwise you're not going to necessarily solve the problem. So that's one thing. So as we thought about some of the limitations that we got in our workforce development efforts is we need to get beyond this. The CNA to LPN glide path's great. I mean, I think we told you guys, they start at $22 per hour and they go up in a year and a half, they'll be making $36 an hour. And 3 years later, they'll be making $39 an hour. That's still lower than 100% AMI. So if we really want to get people to come into a glide path, we need to continue to build above that, right? Or you need to provide housing costs, right? I don't know about you guys. I don't know who can afford a house at $22 per hour, period. Yeah. So that's the problem. And the way healthcare, as we all know, healthcare pays all the big bucks to the hospitals. And so therefore we need to redesign the reimbursement system, because if we're actually going to save the whole system money if we keep people at home as opposed to going to the hospital. So we have to find a way so that healthcare can pay like chore services better, et cetera, right? I mean, I know Caroline, you probably struggle with that a lot, right? I mean, we're limited on our pay for the home care services, and yet sometimes that's what's going to keep them out of the hospital, and that's where I think we're real deficit in the things that we're trying to do on the to get the workforce developed. Does that make sense so far, you guys? Yeah, kind of tracking with me.
Yeah.
Okay, so don't you love my great backgrounds on my slide? It's like a nice white background, but anyway, I did it this morning, by the way, so bear with me. So for the possibilities, we are looking to expand the post-acute care pathway to acute care pathway. So this is a work in progress. We've been talking about training post-acute care nurses, so like people in nursing homes, or training new graduate nurses who want to go work at Queens and Hawaii Pacific Health, but they're kind of the junior varsity, to come to the nursing home and learn how to take care of nursing home patients, because we think that the world will change eventually and there'll be less demand on the acute care side someday. And then they would eventually move up to acute care. So at least that there'll be more workers in the nursing homes that could go up to a higher level, so that they're still meeting their personal dreams, right? The problem is that doesn't necessarily benefit the home and community-based services. And if we don't create a really good pipeline, all we're doing is cannibalizing long-term care, right? Because everybody will just go up to thing and we don't have a pipeline, we never backfill, and we'll actually make our problem worse. So that's something we need to be careful about. Now on the housing side, I'm gonna spend a little time on this. I'm kind of on this quest to see how we could do some things around entry-level workforce housing. And I'm going to get ahead of myself, and Wanell and Troy might get mad at me, but I have talked to Soup and Tammy a little bit about this, because I see that we need to get a critical mass of people, and you don't want to rely only on one industry. And I think about it, and if we were going to build society all from scratch right now, I think the place we would probably start with is healthcare and education. And so the idea is, can we find ways to provide workforce housing for healthcare and education, building blocks of society, right? So that people have this pipeline and then can move up. And I think, Wanell, don't you guys have this new certification program so EAs can end up becoming teachers at some point in time? Yeah, I need to find out more about that. So I've been fussing around with this, and it started on Maui because, frankly, there's going to be a potentially some disaster relief money coming to Maui. So that everybody's talking about projects to help stem the out migration of people and really raise our economic recovery efforts faster. So bear with me on this. So what we're exploring right now on Maui is I've talked to a couple developers, and working one in particular who's an affordable rental housing developer. And I told him, I said, can't you propose a development? Tell me how much money you would need to build rental housing for people making $22 per hour. That was the first thought, right? Let's just see what it's going to be. And, and then it sort of, there was an iteration. We started talking about it going, well, I don't need that many housing, and how many people are you going to get, et cetera. And so I said, well, in addition to that, try and ladder it, just like our workforce development efforts, make housing that can get better if you make more money. And the rule of thumb was we're going to take 30% of income, right? Which is supposedly what you can pay, and try to figure out if you could do it and how much money would you need to do that, just as an exercise, because on Maui there's a possibility. And we said, let's use $500,000 per unit as a rule of thumb cost, which is probably fairly accurate. Yeah. Just so and you can scale this. This is just to give you an example of what we're working on. So we ran a pro forma, and it's really interesting. The way he decided that it could work is, if you could, because my thinking was, we're not going to subsidize. We're going to just give them good, cheap housing. It's not like we're going to pay for their housing. I mean, we want them to enter the housing market and pay their fair share. But we just think that the rates are way too high. Yeah, it's just ridiculous right now. So he said, well, to do this, he would build what do they call roommate units. So it's a rental housing project which has 2 bedrooms and 2 baths, but you're sharing it with somebody. But at $22 per hour, that's 30% of your income. So I put it, as you read across that, this would be a roughly 70-80% thing, is that you could do that, and this would be the rent. It would be about $1,100 per person. And then I said, well, yeah, but what if we can get people up to a higher level? What could we give them their own unit, right? And so we went up, and we took. So what I did is I took the roughly $36 per hour the LPNs would make after a year and a half, and then I think that this is what maybe Wanell and Troy can help me is, I actually looked at EAs and teachers. So EAs make about 21 something per hour, so just around $22 per hour, I think. And then I looked at the schedule. They have this ability to make, as a teacher on a bachelor's, you have the whole schedule, right? It can go from 51,000 to 76,000. So it's about the same kind of income levels, right? And then, you know, we would have some units like that. They would be bigger. They would be actually solo units. So the thinking was, if you could build something like that, would it attract more workforce? Now, we don't know that as a fact yet, but I have talked to people like at Castle Foundation. They said they would fund a study to see what if people would actually take those jobs, because all of a sudden you're in a way subsidizing their income by not subsidizing their income. You're just giving them a cheaper rent, right? I mean, because I think to get I don't even think you could get a unit on Maui right now. I mean, I know of nurses that are homeless. They're living in vans right now because they can't find housing. I mean, it's just not available. And I think Kauai is probably pretty similar. And, you know, I don't know, I mean, I think Oahu, you know, if you had this also, that'd probably be really helpful because we need to grow our workforce. And the thinking is, if you do this properly, you can start, if you have the workforce development effort that's associated with this and an employer, you basically can create a social contract, right? In addition to living there, maybe you help out on the medical respite side, or, you know, whatever, or, you know, you agree to deliver some food, you know, there's social contracts you can do to really make this part of an integrated community as opposed to a housing project. Yeah. Because the last thing you want is like a project, right? Like, let's put all the guys in a corner, like an Animal House. Yeah. And just have them sit back there by themselves, you know? So that was a thought. Now this is just gobbledygook from HHFDC. This kind of puts us in the target of under 60% AMI to under 100% AMI if you did that. So anyway, so we've been fussing around with that. I mean, just so you know, when we did this, if we were going to build this project that we're talking about at the prices, we'd probably need about $25 million, but it'd be about 100 people you would provide housing for. And that actually is a pipeline when you think about it. It's not, it keeps on going, right? The idea is to get them out of this, right? And keep on progressing them to higher levels and you know, that's solving it. And I think that would probably help trying to attract the home and community-based service and the workers. So that's one part of it. I'm gonna stop there. You guys got any questions on that?
I have a question. I may have missed this part, Wes.
Yeah.
So, is the developer the main financier, or is somebody or an organization like yours also investing in it? So that your people are the ones who are really benefiting.
Well, that's a really good question. So when I say donation, it could come from a lot of places. Right now, I haven't identified. For Maui, there's thought that maybe it could be from CDBG disaster relief funds, you know. For other places, I don't mean to speak for the DOE, but for employers, if I knew I could get some workers, I'd put some money into this. I mean, I'm paying over $5 million a year just for one facility for travelers. I mean, could I put in $1 or $2 million? I'd put it in. I don't know. I talked to Soup and Tammy, and we didn't say anything, but I mean, you know, if you could build something like that, I would think
it's within the realm of possibility.
It's possible, yeah. But you'd still need either some kind of philanthropy or like the counties usually have affordable housing funds. So you have to sell this, right? I mean, this has to be part of a bigger picture. I've talked to Weinberg, I've talked to Hawaii Community Foundation, interest in it, but you know, nobody wants to jump in quite yet. And this one is a bigger project. But you know, like on Kauai, we get some property. I'm going, well, wow, why don't we build a rental house on Kauai, but make it for teachers and healthcare workers? You know, like, I mean, maybe that'll work. I don't know if it's going to work. I think we got to test it. But I mean, it seems to make sense. You know, it feels like it got some bones to it, but you do need money. I don't know where it's coming from. Now, there are other abilities to finance it, like low-income housing tax credits. The problem with that is you lose your preference rights. It's open to all based on income.
Right.
Doesn't matter. So I think you want to get through the fair housing things where somehow the preference is to healthcare workers and teachers. And I would love it to be for people that enter into some kind of program that advances their life. You know, so it's again, I like the idea of combining teachers and healthcare workers, and they're all moving up in the world, and they're going to be our next leaders, right? To try to figure out. Anyway, so that's kind of the theory. Did that answer your question?
Yes. I think conceptually it works. I mean, obviously, the devil will be in the details, right?
Yeah,
Whether,
right.
for instance, like, how, if you earn more than $22, will they kick you out? I mean,
No, right, well, I
things like
guess
that,
technically you
right?
can't be-
Yeah.
can't be kicked out, but I think the theory is that, why would you wanna, I mean, I don't wanna live with a roommate. I don't know,
I
like-
know, and I'm assuming, I mean, one bedroom and whatever is really enough for one person, but when they start having families,
Yeah,
you're gonna
right,
need to
right.
find alternate. But again, I think conceptually, I love the idea, and kudos to you for at least talking to the appropriate stakeholders, and
We'll see.
that's
We'll see.
how dreams happen, right? Become
All you need is
reality.
money, all you need is money.
Oh, Senator's here.
Yeah, right. Kenny, do you have?
Hi, Senator.
Yeah, just a quick, I actually, Bennett asked that question about families. So, we're at HPGS, we give out scholarships, right, to students who are interested in nursing or even just like a career in aging. And a lot of them have families.
Right.
So yeah, I was thinking about that too. It's just 2-bedroom. What about, large units?
Yeah.
And then the housing thing, it's not a new idea, and other states are actually doing it. Like UH, they have housing for new professors because the cost of living in Hawaii is so high, and to make it more competitive, they offer new professors housing for a certain amount of time so that they can save up to purchase a house. And I've talked to people who are retired now. They used to teach and work on the North Shore, and they said, yeah, there was, teacher housing there. Again, saving money. And so it's not, I think it's workable. And I know there's housing in Kaka'ako. I forget who the developer is, but he
Yeah.
likes to work with communities, and he has like
I met with him.
certain, yeah, right.
Yeah,
So
Flaherty,
nurses,
Keegan Flaherty. Yeah, I just met with him yesterday.
yeah, he has
Yeah.
parking spaces for nurses at what, 50%, that kind of stuff. It's definitely doable.
Yeah. Well, I think the one thing I think is, I mean, I don't know if it's different. It doesn't matter if it's a new idea or not, but I think that in addition to housing, you got to have the workforce development effort part of it. Otherwise, you're just getting people that are trained and living in housing. In this case, we're trying to lure in more people into the housing that to get in the workforce development. So to me is to try to, again, grab the web whole and, create a pipeline of people that want to get into this field and like get to the point where they only have to work one job, right? And actually have a regional place. But I don't think, I mean, my thought is we got to attract people into this thing. And right now the barriers are the housing and the pay, right? I think, I mean, they may want to do it. They're going to like, well, how am I going to get there? And that's why you need to have an earn and learn, right? An earn and learn would be good. And then you have to have some cheap housing and you have the ability to get out of the housing, right? I mean, they keep on moving up. So, I think there's a lot more needs to be developed and a lot more market research. But I mean, we're trying to see if this idea gains traction, and you could actually keep on going. You could start building housing for nurses and professors and everything. Kenny, to your point, you're right. Is multi-generational housing or family housing is really important. So what I presented to you is just our guests to start getting something on the books. You could do any way you want it. I mean, I tell the guy going, okay, well, now can you throw in some multi-family? I mean, really, seriously, we're at that point. You need land, so like land and you need money, but at least we'll kind of see if we can sell the idea. I think, maybe there's money out there for this, like economic development administration or, whatever. Employers like myself would invest in something like that if I knew it's going to get my workforce. Yeah.
I really appreciate the visionary aspects of this and the attention to health equity and in the details and all the planning. I was like wondering, does social workers count as healthcare workers?
Well,
we fit the category.
No, so you get the next part of my thing is all about social workers and community health workers. Because it doesn't have to be CNAs, right? But because I agree with you, there needs to be this pathway, and it needs to, again, we don't need to make it for CNAs and nurses, but we should make it for industries that are, it's all the stuff we do is for the good of the community. It's not for, profit or anything, right? I mean, we're just trying to take care of people
Sure.
and instruct people. So
And I love how it empowers them to advance and to not need it anymore too, which is awesome.
we'll see. It's a dream. I don't know. Gotta get there. Okay. Can I move to the next part?
Please, go ahead.
Okay, so that's the housing piece.
Oh, wait, Wes, hang on. I just want to recognize Lauren Reich, who's also here. And I know at some point, Senator Moriwaki is right there. Yay, thanks for joining us.
Lauren's
Wait,
from our
you're
office.
muted. You're muted.
I wanted to hear what Wes had to say, but I've had problems with my computer. I think I've been hacked too.
Oh,
Yeah,
no,
so
I
so-
did that, Sharon.
in and out.
I
You
did
wanna-
that so you couldn't hear me. I did that so you couldn't hear me.
I wanted to hear
No, it's a
you.
bunch of
Yeah,
nonsense.
very interesting concept,
It's a bunch
Senator.
of nonsense. I'll circle back with you later, Senator.
Yeah, okay, that's good.
Well,
Great.
if there's anything we can do for Workforce Development Council or any of the folks in the room, I think that might be above the realm of this committee in terms of like our next steps, but we will be certainly happy to endorse or, whatever in pursuit of that effort, because I think I don't know whether maybe the steering committee might want to take it up, but I know for within the bounds of this committee, it might be a little too, outside the boundaries of what this committee is supposed to do. Okay, go ahead, Caroline.
I didn't want to cut Wes off, but I was thinking, could it potentially be part of some of the long-term or mid or long-range goals down the road? So I kind of want to put a parking lot sticker on that because
Sure.
I really liked that concept, because then you're providing those benefits to keep that workforce here, keep them in Hawaii, so that, like you said, Wes, you don't have to have the traveling
Yeah.
staff come in, and then we'll grow it and keep feeding it.
Well,
I think it's,
Yeah, I agree. I think also, Caroline, as I think about it, is this would really work well if it's also affiliated with a HUD senior independent living facility right by, because then you really create a community, right? I mean,
Yeah.
it's social contracts come into play, right?
Mhm.
You get to live here, but go spend some time with your kupuna over there, and then kupuna, you better go talk story with these kids, yeah?
and they are so isolated, especially the
It
pandemic.
it eliminates isolation, right?
Mhm.
But yeah, I think, Bennett, to your point is, yeah, I was worried when I was coming this, because I'm talking about these things that may not really be pertinent for any of this stuff, and
No,
it's,
it is. It's
but-
pertinent. It's
but
just
I
that
think advocacy
yeah.
for this stuff is important. I
agree.
mean, when I talk to some of the foundations, I mean, it's advocacy, and you can't get money unless you have advocacy, right? And
Mhm.
maybe there's different ways. There's different pots and pools. Counties have some money. Maybe the state has some money. Foundations have some money. And employers have money, right?
I'll tell you, one pilot project that becomes successful, everybody will start jumping on the bandwagon.
Yeah.
And why not healthcare?
Yeah. Okay. Okay. So the next one is, to me, is that, let me share. I'm sorry. Go back to sharing. Okay. The next problem I think we got is, the reimbursement for home and community-based service for people to stay home. I don't know, Caroline, you probably would agree with me, right? Is the reimbursement's not enough for people that want to be in that line of work. And yet it is probably the line of work that, if coordinated, would save the most amount of money for the whole healthcare system, right? I think we all agree with that, but we're not there yet, right? It's still, all the money goes to the hospitals, right? But the goal is not to go to hospitals. The goal is not to go to a hospital. The goal is not to go to a hospital, right? So, anyway, we are going down a path of, and Senator Moriwaki was part of some discussions earlier about population health. And I'm going to go real quickly through this just because I didn't make new slides. I just borrowed from another presentation, but just to give this group a sort of an understanding of where I'm thinking is, and this is a national thoughts and models, but currently the way healthcare is done, it's fee for service, right? So let me back up. The way we're reimbursed for healthcare is through insurance, right? And the problem with insurance is there's no more money coming into the funnel to pay for everything. And so right now, insurance gets all this money and it's per member per basis, but yet all the providers are paid on what we call a fee for service. So in other words, you want to get paid more as a doctor, you do more, right? Another test, another, et cetera, right? And there's nothing wrong with that. It in order to make final sense, you need to do more to get more. Okay, so that's kind of the system we're in. And so the conundrum is, if everybody's trying to do more and make more money, and no more money is being added to the system, where's the money going to come from, right? It's the motivations are wrong, right? I mean, everybody says, "Oh man, inflation is higher. I gotta do more," and then everybody starts fighting for the same dollar, and we shouldn't be enemies. We should be on the same page, right? So how do you do that if you're not getting more money? The way that it happens is typically it's going to be transferred to us, right? We'll have to pay more, either in premiums or co-payments, or they'll start shrinking payments to somebody else to pay somebody else more money. Or, for example, if a hospital gets more money out of that same pool of money, somebody else is not going to get some money, right? And it could be doctors, it could be long-term care, or it could be home and community-based services, right? So that's the problem with the current reimbursement system. So anyway, the idea is to start changing the reimbursement model and the system where we're all aligned. So if we all work collaboratively together and we actually save money by keeping people out of hospitals, can't that savings go to fund the things that keep people in hospitals better, like home care and home health and, you know, companions? I mean, social workers, yeah, Tani, right? I mean, occupational therapists, right? I mean, you know, making sure that they have grab bars and there's no clutter in their house, or social worker checking their refrigerators to make sure that they actually have healthy foods instead of cake and vodka, right? I mean, that whole thing, right? That will save the system so much money. But if everybody works together, if they save that money, we could redistribute it to the appropriate places. That's the general idea. So I'm not going to get to, so anyway, what we're doing is we're actually, you know, Senator, we met several months back, and I've been working with HMSA, and we're on the verge of hopefully getting them to pay for some of these services, which, you know, I think over time we can get these insurance companies to start doing it. But we have a company, and basically they're community health workers and social workers. And what we're doing right now, I'm not going to go through this whole thing, but they basically, anybody discharged from the hospital, we navigate them. We meet them in the hospital. We tell them what their journey is going to be. We go and do home assessments. We make sure that as soon as they're discharged, they get medication reconciliation, so they're taking the right meds. I mean, anybody ever been in a hospital, I bet nobody remembers what the discharge planner told them after they've been drugged up for 3 days, right? Nobody's going to remember. And the families aren't going to be prepared for them either. I mean, so we do that, and then we stay with them through nursing home and to home, home health and to home. And we follow them for 60 days post-discharge to make sure that they're managing their chronic disease. They're actually making behavior changes. They have the transportation. If they need to go to see a doctor, rather than going to the emergency room, they call somebody, and we try to manage that. Maybe they just needed some medication changes or something. So so we are working on that, and what we're hoping is going to happen, and we've done this through a grant on Maui, and we're working on Kauai on this right now. And the insurance companies are very interested. Is what it does is it reduces what we call inpatient length of stay, so less time in the hospital, less time in the nursing home, right? And then when they're out there, they don't necessarily go back to the ED or to the hospital, because that costs money, right? And so the idea is, if you save that money, then can it be redistributed? You know, I'm not going to go in all these things, but there's actually literature. This RCT stands for randomized clinical trials. They've done this community health worker, social worker thing on post discharges from hospitals actually saves a lot of money. So for every 100 patients, that's 360,000 in savings. So what we're trying to get, that if we get this paid for by the insurance companies, then we can start trying to move, saying is that, well, why don't you start paying for things like home care, better for home care and for transportation, et cetera, and try to make these covered services. So again, we're working on this right now. I think we're hoping to have a decision by HMSA to start a bigger pilot and maybe even doing on Oahu, hopefully next week. So I guess my whole point, I'm sorry, this doesn't all fit together, but my thinking is that I just want to encourage people when they think about workforce development, you can't think about it in a vacuum. Yeah. You got to solve that it has to pay for itself. And so you need to work on that too. And then you also have to solve the cost of living issues here. Yeah. And so whether it's a glide path where you're starting to make more money, or it's the housing issue, and hopefully you can wrap it all together. So I'll stop right there. I'm sorry, it was probably not exactly what you guys were trying to cover in this meeting, but
No, it was good. Thank you, Wes. I mean, creative ideas. That's what we were looking for, and certainly I wish you well. We wish you well, because
I have a question of Wes. So, hi, Wes. I mean, I like the idea. I mean, this is what the whole long-term care plan was for person-centered care. So, as you look through it, and really we wanted more community-based services. So once you do this pilot, what are your metrics so you show that it's more cost-effective, and what is the time period so that we can tout this and say, even to Medicaid, MedQuest, waiver of programs to be able to fund something that's cost effective. And then looking at the competencies you need for the people along the line that service, because you're going to do more outreach, whether it's social workers or navigators. What are those competencies? So then it does hook in to the workforce development part of it, because now we're looking at maybe different kinds of competencies. Maybe more of some and less of others, but it's not so institutional based, but more community based, and we can pay accordingly for that. So I don't know your metrics, but included in your pilot, and how long is it?
So we're working, we have metrics that we're using, and we used it in our pilot so we could try to prove to the insurance companies that they'll make money on it someday. One of them is what they call 30-day all-cause readmission. So a readmission back into a hospital costs like $27,000 or something like that per readmission, or something like that. Yeah. So, and the literature says if you see your doctor within 72 hours after discharge, right, and after 30, 60 days you don't go back, the odds of you going back are like really low. So one of this readmission rate, which if we show a lower readmission rate, it's the insurance companies are going to know that they're saving money. And it may be down the road, but they're saving money. So just an example, and Aida might know this stuff, but the baseline for readmissions from hospitals is about 13 to 15%. In our trial, we did it. We're running under 4%.
Wow.
Yeah. Wow. I mean, now the insurance companies don't get that money instantly. They got to think about it broadly, that they'll get it, over time. And then the other one is we're going to try to measure reduction in emergency room visits. And there's another thing that's really important to the insurance companies. Not that I necessarily agree with it, but it's patient satisfaction. It's called star ratings. And so the insurance companies get more money if their patients are more satisfied, which is great, right? So like when we discharge people from our program, I mean, we get 10 out of 10 every time, because these poor guys are just lonely. I mean, frankly, people go to the emergency room usually not because of a clinical reason, it's because of a social reason. That they're lonely, they don't have transportation. There's a crisis. They're already on the edge on the clinical side. So that's what we're trying to do. And then we're trying to say is, okay, insurance companies, if you save this money now, put this money back into the community. Now, our model is not a clinical based model. Our model is a social model that we believe that it's going to be you know, there's doctors and nurses out there. So we need people, I mean, you know, transportation services, food services, you know, again, home visits, et cetera, because we don't want to compete with the clinicians, right? We want to support them in their goals. So I think that eventually we had some training, kind of community health worker training, and we brought in some from the mainland. So it's a thing. And what we're finding is we need to build this pathway, just like the CNAs to LPN, of these community health workers to social workers, and then to, you know, LCSWs and MSWs, right? I mean, you need to build this pathway because frankly, if we don't, then we'll lose all of these people anyway, and we're not going to be able to provide this service, right? So
Audrey yeah. Thank you, Wes. Audrey had a question.
sorry.
Yeah, actually, it's not a question. I just wanted to kind of talk about what Wes is talking about, because there's a project that I was engaged in with the Executive Office on Aging almost like 10 years ago. It was called the Hospital Discharge Planning Model, in which Kauai County took the lead on this project. And I was with the UH team that did the evaluation. Very, very successful reduction of readmissions. And the coach, the transitional coach, she wasn't an RN. But so it didn't require an RN to do this, but nevertheless, it was exactly what you're talking about, of following the patient, making sure that they understand the discharge planning, going to the home. And what was the best part about this was that individual, because she was linked with the Kauai Office on Aging, she was able to set up all the linkages to the other resources that the ADRC, the Kauai office, could provide. So there was additional link and transitional to the community-based services. So that was a study that we did. I think it was published in one of those medical journals. And Caroline, we'll have to look for it because I can't find it on my computer.
I
here
think
at
it's
work.
on our
I know
website.
about
I'll
it.
check
Actually,
Yeah.
actually, I've been teaching the fellows about transitions in care, and there are lots of models in the past decade or decade and a half addressing this transitions in care, and they have a lot of similarities. I can send you that summary if you want, and then it has the reference for that article you're talking about on Kauai.
Yeah. So the key thing though is, Wes, that the bottom line too was about the reduction of readmissions, the cost. Yeah, there's definite cost savings to the insurance company, because then they wouldn't have these very expensive readmissions, right? Not to mention the cost on the individual's care and the person's overall health. And like you said, a lot of time it is more the social factors. When the transitional coach went in, they found out they didn't have food, you know, or they didn't have access to purchase the medication that was prescribed upon discharge. So there's a lot of things like that really would make the difference upon a successful discharge. That was one thing. The other part that you also mentioned, Wes, was about the different model of financing, and the other concept is capitation. And so MedQuest, when it was designed, initially had that thought about the capitation model, where if there is more emphasis in home and community-based services, for the insurance company, they save than putting them in institutional care. So the incentive is right up there, right? With the capitation, you put them in home care, daycare, and not put them in nursing home, which is the most expensive form. So the PACE model, it clearly demonstrates that success, right? So there's another model like that. And the last thing I wanted to mention, which you didn't touch upon, but it's important to also look at when you look at for workforce, it's about the messaging, the positioning and messaging, and the image building that we have to do about our industry. You know, it's not sexy. It's just not sexy at all. So while it's really important that you look at housing and compensation and skill training and education, we've got to make sure marketing, positioning, and branding this, it has to appeal to this very special group of workers who really be attracted to working in the long-term care field. It takes a really special person, but you got to make that appeal to them. So you're going to have to incorporate a really great public relations marketing program to go alongside with everything that you're doing. So just want to put that part in. Thanks.
You know, a couple of things, if I may. Yeah, no, I agree with you on everything that you said. We are actually also, one of the things that we have an advantage because we also have nursing homes, is that the big savings is also getting them out of the nursing home faster. And I also have a home health agency. So the idea is to attract the insurance companies. It's not just about the community part. Is they're really looking at the almighty dollar, right? And the most expensive care is the institution. So you got to get them out of the nursing home fast, but yet in this safe way. So we're working on that. And then just one other thing, Dintry, then I'm sorry, just babbling a little bit, but I am trying to bring in, capitation is definitely the grail in a way. So we actually are talking to two consultants to bring in. One of them actually wrote the 1115 waiver for Judy. So I'm going to try to meet with Judy on this. She knows we're doing this, and not necessarily a DSNP, but we're trying to look at a capitation from DSNP. So that's the Medicare, Medicaid, Medicare people, kind of like a PACES model. But we want to try to make it built for Hawaii as opposed to trying to do what they do on the mainland. So we're trying to pick the consultant now, and that might be a really instructional, especially since they've worked on our Medicaid waivers already. So but they're expensive consultants. So
Thank you.
we'll sort of see how that goes. I'm sorry, I'll stop there.
No worries. So Daintree and then Senator Moriwaki, we'll have those last two questions. If you have additional questions, please reach out to Wes. I'm just trying to be mindful of our time. So Daintree first and then Senator.
Thank you. I'll make it really quick. I shared an email with Caroline just moments ago, Wes. And when you're talking about the housing, I remember the presentation I went to, and I believe it was one of the home houseless groups, HIAC or something. I can't remember. But Aspen did something just like that for affordable housing. And they had to be a worker there, and they had purchased a home for like, making up a number, 125,000, where the market would have been over $1 million. And so I sent that to Caroline just as a placeholder because there's some models out there, and that sounds just fantastic. So I'm really, really excited about that. Then a second thing, I just wanted to let you guys know that with the home and community-based services, and us two have been working with Judy Moore Peterson. I'm so glad you're working with her for other options. We've been starting a pilot project for a couple of years now, where we're bringing high school students to work with the elderly and people with intellectual and developmental disabilities. From high school, we pay them a stipend for that internship, so they get 40 hours. And in order to work in home and community-based services, you need like 40 hours of training working in that field. So we've started on Kauai, we have a few on Maui, and now we're going to Honolulu. So that's something that, I want to let you guys know, and how we could expand on that, giving those individuals that opportunity, because healthcare is not just personal care. And a lot of students think that, hey, I just don't want to bathe people all day long. They don't understand the joy of the interaction, going out and doing so much more of accessing your communities. And so we're trying to expose people more to the working, not just the personal care, but actually just the care involved in community. So I just wanted to bring that up. Thank you so much, Russ, for what you're doing. Thank you, guys. That's it.
Senator, go ahead.
Okay, so yeah, I really like the model that you're presenting, but I want to see how you put the money back in, and the money back in not just to insurance companies, but the we talk about incentives and what can we do to get more people into the field, and the compensation is pretty low. So, how do we look at the competencies or levels of as they go up the career ladder or being promoted? How can we incentivize in terms of salaries, because their salaries are so low, that if you can look at as you pilot it, how can you provide those kinds of incentives? Some is recognition, as Audrey says, that this is a noble profession, but in the end, they've got to make ends meet. So how do we incentivize by giving them the compensation in terms of some competencies when they go through training or something? They get a little bit more, as they go along, or something like that we can get some metrics on what things really work. So that was just a comment I had. Yeah.
Thank you, Senator. So Wes, thank you very much for presenting. We really appreciate the innovative approaches, the ideas. I'm gonna just ask Kendi to talk about the priorities, like in 2 minutes, and then Caroline with the big picture. And then we're gonna need to close. I'm sorry, because I want to be mindful of everybody's time. We did just allot ourselves 1 hour for this. Am I wrong? We started at 1:30, right? Yeah, I can't believe the hour passed that quickly.
Sorry.
No, don't be. No, no, no. You know, it
That's
was
a lot
very
to
Oh, that was
say.
good.
yeah, yeah. And you know, we mean it that
Mhm.
we want to support you, and I
That's good.
think there's a lot of good ideas percolating, and I know at some point that's all going to go back into, you know, like you said, a parking lot. We're parking it for now, but at some point it's going to connect to the big picture. So, Candy, please go ahead about our priorities and where we're at as far as the survey.
Yeah. So we did, so, you know, I think Wes kind of summarizes what we did in the CSG conference, right? We talked about the system that we want and how do we finance that and what are the workers that need to support that system. So we're just focusing on the work side. So not just kind of grabbing a piece of the web. So
Yeah. Do you want to share? There were 6
Yep.
priorities. Yeah, there you
Yep.
go.
So this is, let's see if I can make that a little bit bigger. There. So we did take from the posters in the poster session, and for workforce, I did send out a survey for folks in our subcommittee to prioritize. And so these are the whoops, my email there. So these are the areas in recruit, retain, and what's that third green one?
Train.
And train. So what we were thinking was, I think we have a short time frame to kind of develop what are our next steps. And so we were thinking that folks could look at which area they would want to work in. Do they want to look at recruit new people for CNA by increasing enrollment, or to attract and incentivize careers in long-term care to different audiences? So that's where Audrey's talking about how are we messaging this? Or are we looking, do you want to focus on retaining the workers that we have by increasing the wages for long-term care workers, but also broader reimbursements from insurance companies for community health workers? And the last one on training to streamline student internships and externships, or promoting training programs for folks that are outside of the CNA nursing ladder. So that's a quick summary
Thank you.
of where our survey is at.
Thank you. And then Caroline, if you can talk
Okay.
about the master plan, where we're at legislatively.
Okay, so all of you know that Act 159 was signed into law that allows us to establish a long-term care planner here at the Executive Office on Aging, and also requires us to report back to the state legislature in the next session about the work that we've started since the summit. So this group, this is a workforce group. We have our systems and services work group. We have our financing, I call them subcommittees, financing subcommittees, and also the quality of care. So and then we have the steering committee. So the steering committee is made up of the leads on all of these 4 domains. And we will be getting together to really create the framework of what that report's going to look like. And I have a lot of ideas around that, but I'm not going to get into that. I want to be mindful of the time. But our next meeting for the steering committee is Wednesday, August 21st. And I'm sorry, I was trying to find the exact time on that, but I will be sending that to all the leads. And I'll also be sending some instructional things to help frame that meeting on the 21st. But that's the group that's going to take the ideas from these subcommittees and filter it through to help with that report that we're going to be sending back to the state legislature. And once we have the long-term care planner on board, is really collating a lot of these ideas, looking at short-term, mid-range, and long-term goals to create an actual plan to move forward. Was that good enough, Annette?
Yes, I don't envy
I
your
have,
job.
I have a question. What is your
Good.
time frame for the staff? Because we need a
I
staff.
I was
Oh,
gonna
yes,
ask the
believe
same
me,
thing.
I'm
I was-
in total agreement. Yes, I need that staff person. It's been sent up to Department of Health. It's there. They're working on getting that moved forward. So all the
And the-
paperwork's been submitted.
So the funding is released for the worker, the staff person, and you have a position description that's up to
Well,
DOH?
first you do the request to allot, expend, and establish. So that's gone up, and then we're working on the JD right now, the job description.
Yeah, because if you don't have a staff person, it's kind of hard to put all of this together for next
I
session.
work on it at night.
Yeah.
Yeah, and we're very short-staffed here too, so we figure out when we
Okay,
can,
Great.
yeah.
If you need help, let me know.
Okay.
Thanks.
I think had to leave.
Mhm.
Oh, I just, you're still there. Okay. You wanted me to share something, yeah? Okay, so I think we have to meet again to really map out the next steps because, we didn't have any more time. If you don't mind, it's gonna be a quick, even half an hour, just touch base on where we're at so that we can then contribute to the steering committee. Because, and I think, Candy, if you don't mind, perhaps we need to get the guidance from the steering committee. What do you think? And then we'll divide and conquer. So, because based on the six that we have as priorities may not even end up on that master plan. What do you think,
Yeah.
Candy?
No problem, but I mean, if it's it, I think we also talked about meeting with legislators before the session starts in November. So that's what I'm saying. It's a short timeline. If you want to grab the whole web, let's go with Wes and delineate that out. I'm good with that. And then, we can build out the specific workforce areas because even just, streamlining internships, externships, that's a whole nursing thing that they have really spent a long time doing, so we could support if there's already a bill or efforts that we could support, that's what I'm thinking because of the short, you have 2 months, right?
Yeah.
So-
Senator, do you think it would be a good idea to have the different committees meet with a particular senator that's involved in that effort? For instance, workforce would be like labor or whatever. And then,
Yeah.
or should it just be one
No, I think
cohesive
you should.
effort?
Yeah, I think you should meet with the subject matter committees, but I think you need to, I'm not hearing, maybe the other committees are coming together, services and system.
Oh, yeah, we met
But
yesterday.
you've got to have the whole picture. So if you came to WAM, for example, we'd say, what's your plan?
I know.
You've got to say, okay,
Has
it's
to
the
be
workforce,
aligned.
and this is what we're doing in the workforce, and it relates to this long-term services.
Yeah.
And here's what we're doing with a survey. So we've got data to input so that we know that we're on the track, right? But if you just say, okay, we're gonna meet on having another career ladder and social work, it's all parts of a lot of little programs, and how is it connected? So I think if the three groups met together once at least to say, here's where we are, how does that all fit together, like a jigsaw puzzle, how does it fit together? And then everybody has a big picture, and then they go off and they do their part, the training part and how we fit, or the services part, how do we fit, the financing part, how does it fit? And so like Wes's project is boots on the ground. This is how it fits together because here's how it's done. And we have a pilot and we have some federal money. Always nice to bring in money from other places in the state. So, then it makes sense and people get excited about it and they want to then say, okay, yeah, we need the training part or we need the financing part. How do we do more reimbursements with MedQuest or Medicare or whatever we have to do? But now they have chunks of it that they have expertise in that can contribute, but where is that all taking us?
Yeah.
So I think if you folks met, I don't know where the other committees are, but you met one time and looked at this big picture and say, okay, this is how, at least how the puzzle fits together is a big picture. Then you segregate Then there's workforce development, then there's housing, if you want to go that route, right? Then there's ways and means for some of the funding. Then there's DHS, the Human Services Committee, and you got to do both sides, Senate and House.
Yeah.
So, and ultimately, you want to get to the agencies, well, EOA, Department of Health, DHS, to support it. So when they come forward, they come up with a bill that's an executive bill. It's so much easier for us to support it because it's an administration bill, you know? So I think you have to look at it in terms of what is this big picture of person-centered continuum of care and financing all the services that we need. Where are the PUCA? And this is why we need to focus on this coming year, like that. So, I mean, I think
That makes sense.
you know, the projects are really good, but you need to say, okay, where does it fit in the, you know, the scheme of
So
things?
we're gonna, from just hearing from your vision, I think we need to wait until the big, the steering committee meeting on August 21. And then after that, maybe a week later, we'll have this subcommittee meet again. Because I think we need some direction as far as how that's going to proceed.
Yeah,
So
and
we
you
could
take the long-term care plan, the 1988 long-term care plan, because you have something there, right? Dust it off and see, okay, what things are relevant, because some of it is good. I mean, most of it is good. You've done some of it, but we've done this. Here's the PUCA. Here's what it's evolved to, you know, and see if you can make
Maybe,
it more modern. I don't-
Caroline, maybe that's the homework assignment for the leads.
Well, and that's what, yeah, and that's how I had envisioned it, is that we would have some background information from the 88 plan, and then, and I have some framework stuff I put together. I just haven't conceptualized it fully, but that's how I kind of saw the plan. I mean,
Because you're really not
report
starting
anyway.
from scratch. You
Oh,
really
no,
have,
I'm not, yeah.
it's
that's what-
old, but you know,
Yeah.
it's still relevant, I think, a lot of it, if you
Oh,
just did.
definitely. And I think, you know, and the assignments that I gave to like my, for the long-term, I'm sorry, the services and supports was really to look at, and I've misplaced it, but look at what are their goals and objectives that they want to do in the short term? Does it require legislation? Don't reinvent the wheel. What's out there? What's working? What's not working? What's the gaps? And what do we need to bring forward to fill those gaps? So very
Yeah,
similar
just
to
one
what you were
suggestion
saying, Senator.
that I mean, I work with all the vulnerable. So, you know, in homeless, I think what are the data sets you need? So you're always collecting the same kind of metrics. So so if this is the big picture that you have, what kind of data, like Jack Lewin has, he says he's going to collect all these data, right? What kind of data does he have? What does Judy have? What do you have? And as Wes does his pilot, where does it fit in terms of, you know, the kind of data sets we need to actually show progress and show PUCA where we need to be working on, because, you know, it's not filled. So,
Okay.
you know, something like that. So I'm not taking any more time, but I mean, that's kind of the other part is having some data.
So I'll demarcate the date after August 21, and I'll send you
Oh, good
folks
idea.
a copy, I mean, an invite. But could you provide us a copy of that plan again? Maybe I know it's in my inbox somewhere, and then I'll circulate it to everyone for their bedtime reading.
And I can attach, if it helps, I'll attach the slideshow that I did at the summit, because it talks about what that plan was and all the stuff we did from 1988
Excellent.
to
Excellent.
2017.
Excellent.
And
Excellent.
yeah, and the
Okay,
programs that we're putting
touch
in
base with
place.
that. Okay.
Okay, thank
All
you.
right.
Thank you.
Everyone,
Thanks,
thank
Wes.
you. We'll
Thank
have
Keep up the good
next
work.
steps. Take care. Aloha. Thanks,
Bye.
Wesley.
Bye.
Thank you.
You exceeded our expectations.
Always.
Take care. Aloha.
Bye.
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 Thank you. Bye.